All right. Welcome, everybody. Welcome to the UVA Medical Center Hour. Welcome to those of you with us here in the auditorium. Welcome to those of you who are on Zoom. I'm Justin Mutter, Director of the Medical Center Hour, which, as many of you know, is a program of our Center for Health Humanities and Ethics here at UVA. Today's event, the annual Jessie, Stewart, Richardson Lecture at the UVA School of Medicine, affords us an opportunity to turn to the ever-pressing question of quality and value in healthcare. This lecture series is made possible by the extraordinary generosity of the Richardson family. For those of you who are not familiar with this lecture series, Dr. Don Richardson, an alumnus of the UVA School of Medicine, established this lectureship in the late 1990s, shortly after his mother tragically died at UVA Medical Center from a medical error. Ms. Jessie Stewart Richardson had been a teacher, and the spirit of this lectureship has always entailed an invitation for us to educate one another, to encourage one another, to build and sustain high-quality, person-centered care throughout our communities. And today we are honored to continue that tradition. A brief word about the structure of our time together today. As we are both in person and on Zoom, when the time comes for Q&A, we'll have microphones circulating for those with questions here in the audience. For those of you on Zoom, please enter your questions into the Q&A tab at the bottom of your Zoom screen, which we will relay to our distinguished speaker. I'm delighted now to introduce today's moderator, who will introduce our speaker, Dr. Tracey Hoke. Dr. Hoke is well known to us at UVA Health, an award-winning pediatric cardiologist who has served in many leadership roles throughout our institution. Dr. Hoke is the Chief of Quality and Performance Improvement here at UVA Health, and also serves as Acting Director of the Department of Population Health. Dr. Hoke.
Good afternoon, everybody. I have the pleasure today of introducing our speaker, and our speaker is Dr. Peter Paige, our inaugural Chief Clinical Officer here at UVA Health. The Chief Clinical Officer guides clinical operations and quality of care throughout the entire health system, spreading best practices across UVA Health to ensure excellent patient satisfaction and outcomes. Dr. Paige comes to UVA Health from Albany Medical Center Health System in Albany, New York, where he served as the Chief Executive Officer of the Albany Medical Center Hospital. In this role, he provided day-to-day oversight and leadership for Albany's academic medical center. He previously worked at Jackson Health System and the University of Miami, where he served as an Executive Vice President, Chief Physician Executive, and Chief Clinical Officer. As Chief Executive Officer of Albany Medical Center Hospital, Dr. Paige worked to shore up the hospital's finances, erasing a budget deficit while maintaining high-quality patient care, as well as an excellent educational experience for doctors in training. As Chief Clinical Officer at Jackson Health System, University of Miami Health, he oversaw care quality, patient safety, clinical research, graduate medical education, and all the health system's chief medical officers. Dr. Paige earned his bachelor's degree from Lemoyne College and his medical degree from SUNY Upstate Medical University, along with a master's in medical management from Carnegie Mellon. He completed his residency in emergency medicine at the University of Massachusetts Medical School. And please join me in welcoming Dr. Paige.
Thank you, Tracey. Appreciate the kind words and introduction. Very excited to be here. Thank you to those who showed up in person, and thank you to the group that are watching, participating virtually. This is a huge opportunity for us to speak a little bit about some of the operational components across the medical centers, both here and across the community health arm. So I'm going to be taking us through a little journey to really show a lot of the initiatives that are already underway, talk a little bit about where we're going, what the future will look like. And then, as Dr. Mutter referenced, we will have an opportunity for questions at the end as we go through this. I always like to start with the first slide, really outlining IT is not my strength. Thanks. Outlining our mission, vision, and values. And I like to highlight a couple points from this slide. Our mission, transforming health and inspiring hope for all Virginians and beyond. We really have four key mission areas: clinical care, education, research, and communities. You're going to hear me talking about communities a lot throughout the body of this lecture. I mean, we're really here as both the medical center and as the health system to include the 3 community hospital sites and their off-site locations. To really talk about, you know, our communities and how we service our communities. How do communities benefit from what we do, and how do we make ourselves as accessible as possible to our services? You know, it's great to have a hospital. It's great to have great specialists. It's great to deliver great care. But if the people that we're serving, the people that we're here for, can't access us, you know, it's really not an ideal model. I'm going to talk a little bit about our ASPIRE values: accountability, stewardship, professionalism, integrity, respect, and equity. And I'm going to highlight a couple areas just that popped out at me as something that would be a great kind of preface to the ongoing talk. Accountability: acknowledging and assuming responsibility for where we have succeeded and failed in terms of our actions, decisions, policies, and results. Accountability is critical in healthcare. You know, we have to be accountable for what we do. We have to hold people accountable for what they do and what the expectation is for them. But even more important is we have to learn from opportunities we identify as we go through our roles. So not everything's going to work well. When it doesn't work well, why didn't it work well? And when we identify why it didn't work well, we have to implement changes to make it better. It's really a continuous performance improvement model. I want to talk a little bit about professionalism. Approaching all that we do in a collaborative way, delivering excellent care through the lens of helpfulness, positivity, kindness, and competency. We're role models, and you may not appreciate it as much in your current roles, but we're all role models. We all have a certain amount of experience, and we all hold roles in the healthcare organization that other people are going to look to, hope for mentorship from, and learn from. And we have to remember that in our day-to-day activities as we go through our roles in the healthcare system. And equity: this is kind of an obvious one. Fostering an environment of belonging that promotes justice, equity, diversity, inclusion, and unity throughout the organization and within the communities we serve. You know, we're here for our communities. We represent our communities. We provide care and services to our communities, and our staff represent our communities. And that's always got to be a cornerstone of what how we approach a lot of our challenges going forward. In 2022, UVA Health launched a 10-year strategic plan. A lot of great work went into preparing this release. This is kind of an overview of the model. You'll see right at the top: cultivating healthy communities and belongings for all, community engagement, and health equity. Again, how do we relate better to the communities we serve? How do we make ourselves there for them? How do we identify what they need? How can we support them not only on the inpatient hospital side, but the outpatient side? You'll see us talking about strengthening our foundation, easy access. I'm going to be talking a lot more about inpatient access today, but there's a lot of great work going on the outpatient side. John Bennett and his team helping to lead ambulatory reconstruction, really trying to make us as approachable, as accessible as we can for our communities. Not only local communities. Remember now, you know, we'll talk about this a little later on, we're a health system across a significant part of Virginia now. How do we service all of those communities and beyond for some of our subspecialty care? Expanding our excellence in enabling discoveries for better health, destination programs. We have tremendous research programs here at UVA. We should be very proud of a lot of the work that's gone into those, but they just continue to grow, doing cutting edge research. And the future is amazing for some of the things that we're going to be identifying, discovering, and coming up with novel treatments for. And we have providers here and specialty care here that's not available in a lot of different parts of the country. How do we make ourselves more available even beyond our communities for these destination programs that really help separate us from a lot of other healthcare systems across the country? I'm going to talk a little bit about UVA Medical Center and then a little bit about the UVA Community Health. As a lot of you are probably aware, there's 659 beds here at the medical center, comprehensive cancer center, #1 children's hospital in Virginia with a level 4 NICU. It's the only comprehensive transplant center in Virginia for adults and children, a comprehensive orthopedic center, $290 million total research funding. You know, this is a big, powerful place, and this is just a high-level overview. We have obviously clinics scattered throughout the Charlottesville and surrounding areas. We also have ambulatory surgery centers, the Ivy, you know, kind of state-of-the-art orthopedic center on Ivy Road. And we also have joint ventures, for example, with Encompass around inpatient rehab. We influence a lot of different parts of this area, and it's far beyond the medical center, but linked to the medical center. And the medical center obviously is the premier academic medical center in Virginia. By the numbers, for fiscal year 23, 26,400 inpatients admitted, 72,153 patients treated at our emergency departments, 40,706 surgical cases, over 2,300 babies delivered, over 8,300 FTEs. It's a big place, busy place, providing a lot of great care to a lot of people, and a big employer for this area. Vital part of the community. Our community health arm, now fully a part of UVA Health, 3 community hospital sites, Culpeper Medical Center with 70 beds, Haymarket Medical Center with 60 beds, Prince William Medical Center, 130 beds, UVA Health Cancer Care in Gainesville, Community Health Medical Group clinics, outpatient imaging partnerships, ambulatory surgery center partnerships. Again, a big presence in the northern Virginia market, and not just the hospitals. Extending beyond the hospitals, provide more and more service to the communities, and a great addition to the UVA health system. By the numbers, again, for fiscal year 23, 16,506 inpatients admitted, over 110,000 ED visits across their 3 sites, 8,439 surgical cases, almost 2,000 babies delivered, and 2,695 FTEs. Again, busy, big presence, big employer, and a big part of the Northern Virginia market. I say that to kind of set the framework, the groundwork for what we're going to discuss across what takes place across these different areas. I think that, you know, it's a pretty impressive health system, and we're continuing to grow. And I really want that message to resonate with folks both here and on the virtual connection. We're going to talk initially about the transfer process. And there's a method to my madness. As we talk about the future vision, the transfer center process is going to be part of that organizational change that we're looking to accomplish over the course of the next months to years. The UVA Health transfer process at the medical center right now, we have a transfer center in the medical center. This transfer center is busy. As you can see, for calendar year 23, over 10,000 transfer requests processed. However, here, housed with the transfer center is the bed management, bed assignment center. Over 45,600 bed assignments made last year alone. Busy place, connected to the transfer center, but kind of a separate center within a center. The discharge coordination transportation center is also housed with the transfer center and with the bed management center. Over 10,000 discharge rides coordinated for the medical center, calendar year 23, busy center. Our medcom area, UVA medical transport requests. So these are really for UVA Health Air as well as UVA ground transport. 8,702 medical transport requests dispatched through our medcom, which is not in-housed with the transfer center, but several floors up closer to the helipad, which is a pretty cool place to go if you ever get a chance to go up there. But again, it really speaks to all the work that's going on right now in these areas, just for the medical center alone. You'll see these are our transfer requests in the blue line, acceptances in the orange line. You'll see from January of 20 up through March of 24, a consistent increase in both, but more prominent in the requests. Some reasons for this, and one is that sometimes we get outside calls requesting transfer that really just need to speak to one of our specialists, get advice, recommendations, potentially set up follow-up. Some of those patients don't need to be transferred. And so you can see that, you know, our presence is becoming greater and greater in the transfer market. We still have opportunities, but the place is busy, and these folks are working really, really hard to accept all we can. The current transfer process at UVA Community Health, completely different. Incoming transfers are largely coordinated by nursing supervisors at the different sites. So somebody calls in, nursing supervisor helps get them to find a provider that can accept the patient, make sure we have the services and the capacity. And then the referring site will arrange for the logistics to transport the patient to our community hospital. Outgoing transfers are largely practitioner driven. One of our providers will call out to another site, speak to a doctor at another site, ensure that that doctor is willing to accept the patient. And then we go through the process of arranging transportation to take the patient from one of our community hospitals to that other site. And you'll see, this is an interesting slide. This is from UVA Community Health. And these are transfers that are sent out of our community hospitals. And so you'll see over the past several months that somewhere between 200 and 250 transfers every month are sent out of our community hospitals. Now, some of those patients do come here, and some of them go outside of our health system. And sometimes that may be because we don't have any space here. You know, we've been very busy. We're boarding in the emergency department, oftentimes boarding in the PACU as well. The system is pretty stressed with the current volumes, but considering there's still a significant number of patients that need different levels of care coming out of our community hospitals, is there an opportunity to better manage that population that we could take care of here? As we talk about the baseline transfer situation, I want to talk about some operational components of our medical center and of our community hospitals. I'm going to run through emergency services, perioperative services, and patient progression. I really want to make more and more people aware of all the work, all the great work that's been done in all these areas, and the ongoing opportunities and the ongoing efforts to continuously perform better in all these different critical services. We're going to talk about the medical center first. Volumes have increased significantly over the past couple of years. The demand is out there, you know, and some of it's probably post-pandemic, but we are seeing increasing volumes at the medical center. And remember that, you know, we staff to certain volumes, and we staff to certain surge volumes. And as volumes increase and demands increase, and able to accommodate those increasing volumes and higher acuity, we oftentimes have to shift staff and add more staff in response. This is a volume trend for the medical center ED 2013 to 2023 and 2024 annualized. You'll see in 2013, we were less than 60,000 visits that year. Annualized volumes after the first quarter of 2024, 74,104. You'll see the downward turn over the pandemic, but you'll see that the volumes have really responded and grown since that time. And over the past couple of years, we continue to see increased pressure on our emergency department. Traditional emergency departments, and as Tracey mentioned, I'm an emergency physician. It has been sequential processing. So if you think about a patient coming into an emergency department, historically they'd get seen by registration, go through the registration process. Registration process is completed, then they wait for triage. They get triaged. After triage, they wait for a provider. They get seen by a provider. Provider does their assessment, orders tests, orders treatments, does reevaluations, test results come back, and a disposition is made. Sometimes that's discharge, sometimes it's admission. If it's admission, is there a bed? If there's not a bed, the patient tends to end up boarding in the emergency department until an appropriate bed is available. In a program that was launched last year in our emergency department here at the medical center, they started a parallel processing project. And instead of it being sequential in the first part of the ED visit, they're actually doing things collaboratively, almost simultaneously. And so the registration, triage, and provider evaluation are occurring real time together. Obviously, you can imagine the benefits in decreasing time, especially as it relates to the sequential, old, historic way. But it also builds a collaborative model for the team. Promotes a higher level of care, gets the patient seen quicker, gets them through the first part of the visit quicker, and gets the testing done quicker, and allows people to reach dispositions faster than they could in the historical old model. Now, how did we do that? And we call it the PIT, or physician in triage method. And really what it is that based on volumes and trends and waiting rooms, wait times, They've augmented staffing to allow a provider out front to work with triage and registration to parallel process these activities. And so registration, triage, and provider evaluation are all working together to get the patient. And this is all patient-centric care to get the patient seen quicker, evaluated quicker, and then tested and dispositioned faster. And you'll see from the metrics some of the benefits. I want to highlight a couple of them. You know, we talked about the daily volumes. 2022, the daily volume was 181 patients a day. In this first quarter of 2024, we're up to 206 patients a day. For an emergency department that's busy, and that's constrained even with the newer department look that we've got now, we're still constrained space-wise. 25 more patients a day is a big number. And you'll see that the impact of some of these initiatives that we've talked about, length of stay overall, admit and discharge is on a downward trend from 2022 to 2024. Probably the most impressive metric, if you look at 2022 and left without being seen, 5.2%. So 5.2% of the patients that came in to the emergency department in 2022 left without being seen by a provider. In 2024, that number has dropped to 1.8%. 2%'s a great target, benchmark target for an academic medical center. So getting down below that while handling an increased volume and decreasing length of stay is a testament to our ED staff and our ED leadership team. The community health side, it's very similar in parallel processing, but they call it the ED vertical care model. In emergency department lingo, ED vertical care really refers to those patients who are ambulatory, who could sit in a chair as opposed to requiring a stretcher during their emergency department stay. They're usually lower acuity patients, oftentimes level 3 to 5. And what we've developed in our community hospital emergency department is a mechanism by which these people can be seen quicker out front, along with registration and triage by a provider. They can be classified as a vertical care patient, and a part of the emergency department that wasn't used that much was repurposed, where chairs were aligned for patients to sit in while they sit and wait for the process to go through in the emergency department. So provider sees them, they've been registered, triaged, they go to the vertical care ED, so to speak, ED within an ED. They sit in a chair and they wait for their test to come back, they get treated, and then the disposition process happens much more quickly. But it also allows, the patient, when you're seeing quicker, it just seems different. Your ED experience seems different. Even if you're sitting in a chair, if you don't need a stretcher, sitting in a chair is fine as long as you feel like you're being taken care of and paid attention to. And so the keys to success, it's really buy-in. The staff really need to believe that this is the way of the future. As demand increases, we have to take care of more patients. Patients vary in their acuity. How do we come up with novel approaches to better manage the populations that we're seeing? And this extends beyond nurses and providers. This is techs, this is secretaries, this is lab, this is radiology. Everybody needs to buy into this philosophy. And the benefits, safety is probably number one. We've all heard stories about patients in emergency department waiting areas that haven't been seen, that have bad outcomes, and it's oftentimes because of prolonged delays to being seen by a provider. This obviously mitigates a lot of that risk. Patient experience. If any of you or a family member have been in the emergency department, one of the biggest deterrents to wanting to go to an emergency department is the wait. And it's the wait out front, it's the wait when you get back, it's the wait after the provider sees you, it's the wait for a provider to come back and tell you what's going on, what you're going to do. And so this kind of a model obviously improves patient experience in the emergency department. The last thing that's really important is that if you think about it, historically, oftentimes patients that didn't require a stretcher would get put on a stretcher, because patients will come in and follow the sequential processing for emergency departments. Well, now when you use chairs for the people who it's appropriate for, you're freeing up the stretchers for the people who really need the stretchers, so that when new patients come in, you tend to have more capacity on the stretcher side. And this is a left without being seen slide for the community hospitals. You'll see over the past couple of months as this program matures, significant decrease in left ventricle scenes, but it's all very, conceptually alike. And I think everybody in this room and virtually can understand philosophic approach to patient-centered care in the emergency department. Again, great success story for the community health hospital emergency departments as well. Perioperative services, we're going to talk a little bit about the medical center. The perioperative leadership team has created a perioperative roadmap. Best place to work, ease of access, superior patient outcomes, and resource stewardship. We're going to dive into each of these more on the next 4 slides. Best place to work, everybody's heard about the challenge with recruitment and retention in healthcare systems across the country. Really tipped over the edge during the pandemic. Post-pandemic, it's been a slow recovery process. The competition for certain levels of staff is crazy, not just within healthcare systems, but even locally at businesses. And how to recruit and retain is a critical skill set that all hospitals and healthcare systems need to be successful. I highlight the goal for RN hiring was 130, and our team has hired 112, many of which already have prior operative room experience. For certified surgical techs, 85 was the goal. They've hired 31, and there are more offers out there. So they've had a great run with recruitment. The other side of this is retention. If you recruit people and they stay for a year or two to get the experience and then they leave, you're really kind of shooting yourself in the foot as it relates to your recruitment opportunities. So we have to be conscientiously working on how we retain people. And a lot of that is around the environment. People have to enjoy it. They have to feel like they're part of a patient-centric, high-quality system. And we have to recognize them. We have to support them. We have to resource them, and we have to make them feel like they're a special part of the team. And you'll see one of the things I like to highlight on this slide, this hiring effort has contributed peri-op reducing external travelers for RN roles to only 9% of total. Everybody knows some of the challenges that travelers bring. While obviously they provide a great resource, when people come in and leave and come back, obviously there's an additional expense related to them. You lose some of that teamwork and collaborative mindset, and it's discouraging sometimes to full-time staff. See people come in, get paid more, doing the same work you're doing, then leave. So the more that we can build into our fabric a consistent staffing model, the more expertise we can get from that team, and the more workplace satisfaction we can get for our employees. Ease of access or efficiency, we're always looking at opportunities, and the team here is no different. First case on-time starts, throughput analyses, turnover times for rooms, having the right equipment available for the procedure, having all the paperwork done before a patient goes into the operative suite. It's a constant opportunity and battle, not just here, but across the country, to improve upon those efficiencies. We talk about right patients and right location. We have a lot of ambulatory surgery center access. If patients can be cared for and the procedure can be cared for as well at an ambulatory surgery site as opposed to coming into the main operating room, we should be trying to figure out how to provide the right care in the right location, keeping the patient's interests and concerns in mind. And what that does is it opens up the main OR for those patients that can only be cared for in the main OR, and allows other people to be cared for in a more efficient location. I talk a little bit about extended hours. Our team has done an amazing job of handling increasing volumes. They're working into the evenings now. They're looking at potentially working on weekends and holidays. I mean, it's really a demanding area. Our teams have really responded at this point. So I'd like to recognize them for that. Superior patient outcomes. This slide is really addressing sterile processing. As many of you are aware, sterile processing is really the cleaning, sterilization of equipment for the operating rooms. And it's really putting trays together, making sure the right instruments are on the right trays for the right surgeon, for the right procedure. It's a huge part of OR efficiencies and throughput. And if you can just imagine a surgeon getting ready to start a procedure and they open up the tray and the key instrument is not there, or it's the wrong size, and they can't find the right size. Those things are enormous disruptors to appropriate flow in the operating room, and obviously put patients at risk as well. And so a lot of work has been done Multiple blitzes have been conducted in the sterile processing world to try to make it more standardized, consistent, efficient, and a much more well-oiled machine. I can tell you from my own personal experience, this is a challenge in a lot of hospitals and academic health systems. And it's one that sometimes I think some places take for granted, and it's work. And it's an opportunity at most places. Resource stewardship, I'll mention briefly. This really relates to supplies and utilization of supplies. You know, when you think about some of the pieces of equipment that can get opened and not used and then have to be discarded because they were open, and the expense related to them, there's a huge opportunity to decrease waste in the perioperative world. And one of the things that we do here that the team, I think it's great, is they post a lot of information about the prices of different supplies for our staff to see. It allows the staff to better understand just what that would mean if, well, I don't really need that, but if I open it and I need it, then it's going to be open for me. And countering that with, well, that piece of equipment is going to cost $5,000 every time I open one and don't use it. And we've had a lot of success here in fiscal year 24, saved over $1 million in the peri-op space alone, relating really to resource stewardship. So again, congratulations to our perioperative teams and the leadership of those teams. On the community health side, you're going to see, you know, some consistent themes: recruitment and retention, you know, and really trying to out-recruit competitors, but also how do you make the workplace experience and the culture and the supportive environment better for people that you bring on board and better to allow you to retain them. You know, people have to want to work here. How do you make it a place that people want to work at? And a lot of that is, you know, that communication, collaboration, being respectful of your colleagues, but also recognizing the great work that's getting done and the patients that are benefiting from that work. Perioperative initiatives, one of the big challenges in the ORs is scheduling. We talk about block utilization. So a block of time is dedicated to a surgeon or a service. And if a surgeon doesn't use their block, trying to get them to release that time as early as possible so that we can backfill that slot, again, to accommodate the increasing demand for our perioperative services. And future goals, sterile processing, again, is listed on this slide. It's an effort across the community hospitals as well because it's such a valuable asset to what we do going forward. And I always love to talk about culture. OR culture is, you know, another big opportunity for us. Professionalism, we spoke some about engagement, collaboration, being part of a successful team going forward in an environment that's not toxic, but is actually a positive opportunity for our staff. I'm going to run through patient progression services. This is really the time frame from patients arrive, they go through the hospitalization, then they're discharged. And there's a lot of intervals that happen that can go well, that can cause delays and barriers. We're going to talk about it a little bit at the medical center where there's been an enormous amount of work done on patient progression. It's a busy slide. We're going to talk about integrated interdisciplinary discharge rounds on the next slide in more detail. I want to highlight a couple other areas. Complex patient initiatives. There are a lot of patients who go through their hospitalization and it's very difficult to place them. You know, and it's for a lot of different reasons. Maybe they can't go home, but they don't need to be in the hospital. Maybe they need services at home. Maybe they don't have a home. Maybe they need to be placed in a SNF. Maybe they need to go to rehab and they don't have capacity, or we can't get insurance authorization. There's so many different challenges that we can face in some of these complicated patients. We have a team, a multidisciplinary team that works specifically on these patients to help them navigate some of these challenges and to help reach a disposition more promptly and really try to move some of these patients who don't need a hospital bed into an environment that allows them to continue their recovery in a safe fashion, but allows us to use that bed for the next patient that's waiting. Active leader involvement. I'm a big believer in leadership, presence, visibility, transparency. And, you know, it's important for us to recognize a lot of the work that people are doing. You know, it's easy to kind of accept the fact that, well, people go in and they do it every day and that's their job. We need to be a little bit more proactive in trying to recognize and reward, you know, staff members that are really going above and beyond to provide the best care they can for our patients. Interdisciplinary rounds, I've had an opportunity to join on a few of these. Very impressive program. There's an overview given of the patient. We run through some quality metrics, Foley catheter present, central line present. Can they come out? Is there an alternative? Obviously in a way to try to mitigate the risk of healthcare acquired or hospital acquired infections such as CLABSI and CAUTI, which a lot of you are familiar with, which obviously are detrimental to the patient. And the longer these lines and the Foley catheters stay in, the higher the risk for these infections to occur. Discharge process. When's the patient going to be discharged? Are there barriers to discharge? What can we do to mitigate those barriers? Is the patient aware when they're going to be discharged? If the patient's a patient that would meet the criteria to go to our discharge lounge, do they know they're going to go to the discharge lounge? Keeping the patient as a part of these discussions prepares them so that when the day comes that they're going to be discharged, they're much more comfortable with the plan if they know it ahead of time. And length of stay has improved. I'll highlight a couple areas. Current fiscal year through December, 6.15 length of stay. Prior year through December, 6.54. In the world of length of stay, 0.4 days is enormous. And it really has a significant impact on us opening up more space and capacity for those other patients that are out there waiting for our services. So great job by the patient progression team and the throughput team, but still a lot of opportunities. A lot of work to do, and that's why I referenced a continuous performance improvement model that I spoke about earlier. Discharge lounge is open. It's a new site off the main lobby. It's big, it's bright, it's clean, and it definitely can accommodate more than the prior location. The medical center leadership team's doing a great job. Bless you. It's doing a great job of further promoting the discharge lounge and trying to make it even more appealing so that patients feel like they're going somewhere special, and that they're not just going down there to wait. But obviously, for example, if a patient is waiting for a ride, and the ride's going to be here in 2 or 3 hours, there's no reason why we can't move that patient down to a comfortable environment, open up that bed so that we can fill that bed with somebody who's waiting for that bed, and allow them to be picked up in the discharge lounge. So great opportunity. Emerging opportunities, I'm going to highlight 2. The ED observation unit is on the horizon, and really trying to figure out how to standardize protocol care for these emergency patients that fit into certain categories and can be managed on a standardized protocol, get them through their hospitalization quicker and safely discharged and appropriately followed up. And improving within-day efficiencies, we have oftentimes a 2 to 3 hour delay from when a discharge order is entered until the patient actually physically leaves the room. Can we work on those processes? Are there things that we can do in the discharge lounge? Are there things that we can do ahead of time to shorten that duration of time from the order to the departure so that then we can utilize that bed more promptly? On the community health side, again, a lot of similar themes. Proactive discharge planning, heavy case management involvement, observation patients in their clinical decision unit, another name for an ED observation unit, clinical decision unit, and really analyzing the hospital throughput and flow initiatives. There are all kinds of intervals from when a patient comes in to when they leave. How do we analyze each of those intervals and try to make them as efficient and as short as possible, obviously prioritizing care for the patient? Length of stay hasn't really moved that much. It's a pretty good number and below their target, but we're still hopeful that we can start seeing a downward trend in length of stay. And discharge by noon has really seen an uptick in February, but 1 month does not a trend make. This is an ongoing effort. This is actually leave by noon, not order by noon. So it's a great opportunity for us. The future, which everybody is waiting for. UVA Health System Capacity Coordination Center. This is something that a lot of big systems, health systems, academic health systems have launched at their places to coordinate standardized approaches to different components of this, what you'll see with the Capacity Coordination Center. Can be very effective, take time to evolve, take time to develop, but definitely something that we're looking at as an opportunity going forward. You'll see our primary focus initially is bed coordination, bed management center, transfer center, discharge transportation coordination, and medcom, which, as I mentioned, is the UVA medical dispatch. And these are the items right now at the medical center that work together. 3 of the 4 are housed together. And we're trying to figure out a strategy to implement this kind of a process in a centralized way for our health system. And better appropriately use our resources and better standardize the delivery of services in all these regards across the health system. So phase 1 overview, this is the system transfer center process. This will be our first step into this world. And it's really trying to design a centralized hub where all transfers in and out of any of the hospitals across our system go through this central port. We'll have specialists in that area. We're recruiting clinically experienced RNs to be our screeners and coordinators through the transfer center process and work with our medics who are currently there. And it's really meant to see what is going on across the system, where patients are going, why they're going other places outside of our system, and is there a way to better accommodate those volumes, either here at the medical center or at one of our sites. I always promote the highest quality care close to home. You know, it's important that we try to provide the service close to where patients are living or from. They have much more support services. They're much more comfortable, much more familiar with the environment. So when we can provide care at a community hospital near where a patient lives, we should be providing care at the community hospital near where the patient lives. Phase 2 overview is discharge transportation coordination. Again, through a centralized hub. Discharges occurring across the 4 medical centers will be run through this coordinated center. And this coordinated center will utilize the resources we have and assign these rides or these transport services to individual patients. Again, standardizing the process, making it more consistent, and hopefully shortening the time from when a patient is called about a discharge ride to getting a patient out into the appropriate care setting. The third one, which is probably the most complicated, is the bed management system. Mature systems do have ways of kind of having transparency into all the beds across the health system, all 4 sites. They know where beds are open, where they're blocked. They know places that are at capacity, beyond capacity. They know the services that can be provided at each medical center. How do you coordinate that? There are a lot of portals of entry. Transfers are only one. The ED, operating room, direct admissions. How do you coordinate all that stuff and maximally utilize our capacity to the greatest extent? Limitless integration. Some places incorporate their EICU into these capacity coordination centers. Really cool models. I was at the model in Baptist in Miami, and they had 24/7 critical care staff. They had pharmacies working with them to monitor all the medications in the ICUs. The critical care attending, 2 nurses, and they monitored all the ICU patients across the system. They still had staff on site, and this team would communicate with those teams, but this is 24/7 monitoring. They had very fancy acuity monitoring systems that allowed you to figure out who's the next patient that could be moved out, you know, subtle changes in vital signs to trigger an intervention. It's really a great quality tool once we get to that level of sophistication. Telemedicine is well known to all, again, centralizing it through this process. And then even things like insurance authorization are great opportunities for us. Again, this is visionary, nothing automatic. It's going to take us some time, but you know, with the leadership team we have in the transfer center, the capacity coordination center, and I see obviously Mladen and Sarah are here, who have really done a great job with all this work here at the medical center, and Deepa, if she's on virtually, working with them to try to figure out how logistically to roll some of these things out without increasing any risk is really a great opportunity for us. You know, I end with recognitions. This is a small group of people, but these are the people that really helped contribute to the slide deck and the content of the discussion. There's so many other people that are so instrumental in all these areas and the success of these areas that I just send out, you know, kind of a shout out to everybody involved in these areas, because they're really doing a lot of great work, and we really appreciate all their efforts in an ongoing fashion. With that, I'll say thank you for your attention.
Thanks to Dr. Paige for that Excellent talk, and we will entertain questions first in the room. I believe John has microphones, if anybody would like to ask a question. Thank you. It's not very complicated. Perfect.
And thank you for your talk. I'm Mary. Mary Jobson Oliver. I'm from Stroke. I'll just say Stroke. So have you experienced, and I might have missed this in the talk, have you experienced capacity issues at the other community health sites, or are we experiencing kind of the brunt of it just because of the type of facility we are? Just curious.
I'm sorry, capacity challenges?
Yeah, capacity challenges.
Yes and no. So the medical center is in a little bit of a different situation because of, the breadth of services and the complexity of services that we deliver here. The level 1 trauma center for pediatric and adult, children's hospital, NICU, PICU. And so that puts a lot more strain on this system at this point. The community hospitals are busier, and they do have challenges in certain parts of their hospitals. And getting patients into certain parts of those hospitals, but it's a little bit more compartmentalized, I would describe it as. But there are opportunities, at least from my perspective, to potentially better utilize some of that capacity in those sites. And some of it too are the resources and services that they can provide at those sites that limit to a certain extent some of the patients they can admit. But they do a great job. They care for a lot of patients. It's just for all the community hospitals, there are challenges. The medical center is just a little bit different by the nature of the beast.
Other questions in the room? Justin, you want to read?
Yeah, we have a question coming in through Zoom, and this kind of reflects some of the questions about communications between providers and teams and patients as we do this amazing work all across the board and systemizing so much of what you talked about. But with these impressive increases, the writer says, as well as the expansion of the health system, what's being done to ensure that communication about patients and their treatment is accurate, timely, and supportive of that safe and excellent care? How do you routinely monitor for those kind of safety risks and communication that might come from some of those challenges?
It's a great question. I'm happy to start, Tracey. I'm sure you'll have some thoughts as well. Right now, as you can envision, we're looking at a model where we're going to coordinate across the health system. And we see opportunities on both sides to enhance the timeliness of communication and the content of communication and feedback on communication. But right now, there are two different processes, for example, around transfers. And so we have transfers that come through. We listen to tapes. We try to provide feedback based on some of the conversations that we review and listen to. We obviously review issues that are raised to us to try to figure out if there are better vehicles to enhance communication. And sometimes it's individual practitioners, and sometimes it's a difficult conversation, and sometimes the answer isn't what somebody wants. But by constantly monitoring those processes, it gives us an opportunity to identify opportunities and then provide feedback. I think that we have different communication strategies and devices here at the medical center than we do at the community hospitals, and the community hospitals seem to work well for them. Ours seems to work pretty well for us. And how do we come up with a model that's going to support both the community health arm and the medical center arm as enhancing communication? I also think that sometimes it's who do we need to talk to? Sometimes we get connected to the wrong person. Sometimes it's the wrong service. Sometimes it's somebody that's not empowered to be able to make that kind of a decision. And so we have to continually work on trying to align calls coming in, who they should be communicating with, to bring closure to that question or escalation. Did you have anything you wanted to add, Tracey?
Yeah, I think I'll add one comment. Obviously, hardwired and standard processes around handoff of care and communication are important, but I think ultimately this comes down to a bit of institutional culture across the system. for everybody who was involved in COVID, you'll remember that pediatric ICU beds are at a premium in this state. And so, and they're also pretty well spread out across the state. And so it became the norm that we had a call, I think it was about every Friday or so, to talk about it. Where were the sickest patients? Where were the ventilators? Where were the beds? Who could take what kid? So that we avoided ever rationing or sending kids outside of the state. And I think that was a really remarkable collaboration in a time of absolute crisis, but it built a culture that lives on today. We have much different relationships with our sister hospitals across the state in pediatrics than we've ever had before in terms of collaboration, whether it's around transfer or services to offer or follow up after a quaternary care service is delivered here. And I think that will come once we have more and different interactions with our sister hospitals and potentially other hospitals that we receive calls from. I know, again, Ron and Sarah will tell you, we get calls from dozens of hospitals across multiple states. And so having a real relationship. I'm so happy to see people in this room as an example, having, sort of warmer handoffs and communications than we've had in the past, I think is going to make a big difference as well.
So I have a question. And this is, I'm just so struck by all the work that's being done. I mean, it's a huge amount of work and a huge amount of thinking across microsystems and to macro systems and different institutions, different parts of institutions. One of the common challenges in quality improvement and continuous quality improvement is how do we kind of twofold? Number one, make sure that everything we do is mapping to the strategic initiatives that you started with. But then secondly, what is the superstructure mechanism to monitor ourselves as we do that? So how do we make sure that the initiative itself is working in the way that we want it to work? How do we choose those right metrics, all those good things? So I wonder if you could speak to that a little bit, just how we make sure as we move along in this journey that we have those stopping points and say, this is exactly where we wanted to go, or this didn't go quite as well, or this doesn't align really well with how we thought it would with the strategy.
Yeah, it's an interesting question. As I, complete my 4th month in the organization, I've met a lot of people, learned a lot, and I've seen a lot of, very successful initiatives that have been launched, in the process of being launched. And there's a lot of really smart, really great, really driven people in this organization that I've already appreciated in a very short period of time. And I think that the vision is created by a lot of those content experts in their areas as they try to help us drive this to a different level. And so I think, the leadership team and Tracey's area and, the leadership team across the hospitals and the community health arm, really need to bring in the right people that can weigh in on some of these opportunities and then help us structure. I don't know all the answers, and I'll be the first person to say that, but I do have experiences which make me stronger in certain areas, and other people have experiences which make them stronger in other areas. How do we feed off that talent? How do we utilize that talent as an organization to take these things to a different level? And I think that's all of our responsibilities. And I think that the message I will commonly speak to is, it may be good. There's always opportunities to get better. And how do we think about this as, critical analyses of ourselves and our teams, not in a punishment way, but to just continue to raise the bar and raise the bar and raise the bar and raise the bar. There's a lot of great performances across the hospital and across the health system, but how do we get even better? I mean, you look at high performing organizations, they never take their foot off the pedal. They're constantly looking at opportunities to get better and better and better and better. And so I remind folks that, we have to recognize when people do great things, and we have to recognize when parts of the organization are very successful. We also have to recognize the opportunities in something as complicated as an inpatient stay. There's so many factors that go into that we could have great length of stay, and there's still going to be opportunities to tweak a little bit here or make a patient's experience better there, or decrease the risk of acquiring hospital-acquired infection. So I want people to remain vigilant.
And I'll make one comment, Justin. All of that and data, right? Like we've got to know where our problems are. We've got to know where we've done well. We've got to know where our investments have paid off, whether that's in outcome or experience or capacity, and maintain that constant state of both curiosity and accountability for the efforts that we put forward, because there's only so much we can do in the day and there's so much to do. So all of that in data.
Yeah, no, thank you. That's excellent. And I think we're pretty much out of time. So just want to thank you, Dr. Paige, thank you, Dr. Hoke, for this great discussion. And I love the metaphor as we end here of keeping our foot on the pedal. And then also keeping that spirit alive of both accountability and curiosity that Dr. Hoke just invited us to. So thank you all for coming. This is our last medical center hour of the academic year. We've got a great slate of events coming up in the fall, so look out for that. I want to thank again Dr. Don Richardson and the Richardson family for making these conversations possible. Everybody have a great rest of your week.